Next presentation is by Dr. Deepak Megur. He'll be presenting on intraoperative hard eye during phacoemulsification and analysis.
Respected Chair, I'll be speaking my sharing experience of intraoperative hard eye. It's a state of intraoperative progressive shallowing of the antechamber, propensity of the iris to prolapse out along with an hard eye during phacoemulsification, and it's a tough situation to be in. We want to report the incidence, intraoperative features, and analyze the etiologies. It's an observational case series of 4,500 consecutive phaco procedures, and we studied the intraoperative features, what stage of the surgery did the sign appear, outcomes and corrective measures. Etiology was deduced into two forms: internal issues like fluid misdirection, suprachoroidal hemorrhage, or external like a tight drape or type speculum. The intraoperative measures we taken was, apart from checking the external pressure source, defer the surgery, do IDO, B scan, IV mannitol in the OR or in the IPD, pars plana tap when it was absolutely sure that we were dealing with an aqueous misdirection, and defer the surgery. 32 eyes, 0.71% was the incidence. Fluid misdirection was the most common cause, and 2 eyes had suprachoroidal hemorrhage, which were sort of limited. And the external source of pressure, speculum pressure, was seen in minimum. In 18 eyes of fluid misdirection, we just had to wait for a few minutes for it to settle down. 2 received IV mannitol on the table. 2 eyes we had to defer the surgery for a few hours, evaluate, and then get back. 2 eyes received pars plana tap, and then the surgery could be continued in the same setting itself. Let me take you through a few cases of different ways of management. When we began the surgery, this eye was very soft, pressure was 8. As soon as the dye was injected and the OVD was put, the eye became hard immediately in just a couple of minutes. So this was, I just did a pars plana tap. You can see the blue fluid, trypan blue letting out. The eye became soft and you could proceed with the surgery. And it was uneventful. The next case is a pseudoexfoliation. And again, the eye became hard after the nucleus emulsification, and just I couldn't proceed with the surgery. The red glow is intact. We gave IV mannitol, and after that, we waited for 15 minutes. I softened. Then I could form the bag. I could place the lens into in the bag and then align it properly. Now, 2 had the PC tears because of the positive pressure, because of fluid misdirection. Pseudoexfoliation is the most common cause for this problem, and presence of a blue glow and fine lens dust particles in the Burgers pair were indicative. The visual outcomes were good in most situations. The problem was really with 2 eyes of suprachoroidal hemorrhage, where diagnosis was very difficult. Although a conservative approach did help because it were all limited. Let me take you through these 2 cases. A very healthy patient, perfect red glow, and now the eye becomes hard before putting the lens inside. The PCS, look at the OVD which is just gushing out, and the red glow continues to be good even at this stage. The eye is extremely hard. I can't implant the lens at this stage. I said I'll just abort. The patient was under topical anesthesia. Axial B scan by my technician showed it was normal. So I said it would be a fluid misdirection anyway. After mannitol, again the surgery is rescheduled. The situation did not improve dramatically. Somehow I could squeeze in the lens, but again the situation was worse. I couldn't align the lens. I thought because the B scan was normal, I did a pars plana tap, but nothing came out. And this was alarm for me. No, I just sealed the wounds, closed all the incisions, and then again, as expected, took him back to the B scan. The central scan was normal. When we do a peripheral scans, we could see these choroidal mounts with hemorrhage there. And this was an eye-opener for us. And just conservative approach did clear up, and I can be extremely lucky, I should say. Another case, eye became hard after the intraocular implantation. One haptic is in sulcus, and I cannot form the chamber at all. I just close it, and this is how the picture. Central scans were normal. Again, when you do the scans in the peripheral area, you could see this limited choroidal excavations and hemorrhage. And again, a conservative management over a period of maybe 45 days, eventually it settled and the patient regained. So to conclude, no, intraoperative hard eye is not very uncommon, and fluid misdirection is the most common cause. But it is not rare to have suprachoroidal hemorrhage. Only thing, diagnosis is difficult. I thought I could never have, just a matter of time. Apna time zarur aayega. That is what I learned from this series which I had. And it's very difficult to differentiate between fluid misdirection and suprachoroidal hemorrhage in the OR, because good fundal glow was seen in all cases. And you can't rely on sharp pain because it's unreliable and subjective. And it's very easy to miss limited SCH if you just do an axial B scan. So because of this difficulty, we would recommend and prefer a conservative approach. There's no point in doing it in the same day. Defer the surgery, evaluate the case in detail by B scan, IDO and IOP monitor, and then only reconsider surgery for when deemed fit. although more glamorous and attractive, it is, I think, very futile to try to poke in a needle in a pars plana, and definitely not do a limited anterivitrectomy, because we could end up having a disaster, because the differentiation is so difficult. It's just about buying some time. We want to live to fight for another day. So that was the message from this paper. Thank you so much.
For the wonderful presentation.
Can you correlate one further risk factor? Age 70 plus myopic case. When AC is very deep, weak zonule, probably fluid goes through zonule.
Yes, see, for fluid misdirection, the risk factors are very clear cut. We have a loss of zonular barrier, that is could be either because of pseudoexfoliation and age. This is very clear cut. But the eyes with suprachoroidal hemorrhage, which we had, they were apparently healthy. They did not have glaucoma. They were not elderly. They were between 60 to 70 years of age. One patient was 70 plus, other was 60, 65. And there was no hypertension history. But one patient, what we noticed was the first case, there was a sudden spike of blood pressure during that whole procedure. Before the surgery, blood pressure when we measured 140 by 90. During this intervention of 3 hours, which we took to the break, the blood pressure just shot up for it and persisted for 1 or 2 days. So intraoperative rise in pressure, blood pressure, for some reason we don't know, that was one of the risk factors for that particular case. And preoperatively, her blood pressures were normal. And both the pressures were not known case of glaucoma or ocular hypertension, nothing. They're absolutely routine cases. The point here is limited suprachoroidal hemorrhage often can go undetected because we're doing a closed chamber procedure. It can happen somewhere periphery, we can't detect it. And every intraoperative eye need not be a fluid misdirection. So it is not wise to just poke in and try to be heroic and do an antivitrectomy, and it could be disastrous in some times. That's the message.
Wonderful presentation. The take-home message is never to poke, wait for some time, and then proceed. Thank you very much.